So welcome everyone. My name is Liz Sharna. I'm the Executive Director of Pathways Serious Mental Illness Society, and we're very, very pleased to have you with us tonight to learn more about anosognosia. Pathways' mission is to alleviate the suffering caused by serious mental illnesses, including anxiety disorders, bipolar disorder, borderline personality disorder, concurrent disorders, post-traumatic stress disorder, depression, and schizophrenia. We do this through support, information, advocacy, education courses, and lectures like the one we're doing tonight. Our advocacy committee reached out to Dr. Randall White, and he's been gracious to accept our invitation to share his knowledge on anosognosia. Dr. White will have a slide presentation this evening and has assured us that he will have lots of time for discussion and questions at the end, and potentially will solicit questions along the way. So during those times, you're invited to raise your hand using the hand icon on the bottom. And then we'll unmute you and you can ask your question. You can also write questions in the chat if you like. I want to be clear tonight that during the presentation, Dr. White cannot make specific recommendations about a person's treatment, and he discourages the presentation of anyone's history in a detailed manner or the use of names, whether patients or doctors. You're welcome still to put your name and where you're coming from as you join us tonight. And now it is my pleasure to introduce you to Dr. Randall White, Medical Director, Psychiatrist, University Teacher and Researcher, and Medical Health Advocate. Dr. White is currently the Division Head for Adult Psychiatry and Mental Health Services at UBC, and the Medical Director for Community Mental Health Services for Vancouver Coastal Health. And we have the distinct pleasure to have him with us tonight. So, Dr. White, we welcome you and we'll turn it over to you.
Thank you, Liz, and thanks to Pathways for inviting me. I am familiar with your group. I actually came over to the North Shore, but that was a number of years ago. Nancy Ford invited me, and it's good to reconnect with you, but it seems like the audience is going well beyond just the North Shore of Vancouver. So I guess that's what this kind of technology permits. Liz and I were talking about that just before we started, that for many of you, it would be difficult to access something like this without Zoom. So anyway, I hope that we can, talk about this topic. And that.
Just a second, how did that happen?
Oops, I got muted somehow. Am I back?
Yes.
Yeah. So, the word itself is hard to pronounce, perhaps, and to spell. And it's not one that, psychiatrists necessarily, have talked about or used very much. And we'll talk something about the history of it. So anosognosia is the way I say it, and I heard my teachers say it. And it has to do with how someone perceives or doesn't their disorder. So the basic problem is, as many of you know who have loved ones affected by schizophrenia or severe mental illnesses, bipolar disorder, anorexia nervosa, or others, that they often don't want to do what we know will help them: go to an appointment, take medication, sit down and have a discussion about, the best way to deal with whatever situation they're in, which can be dire in some cases, as we know. And it's very hard to have a collaborative kind of discussion, which is extremely frustrating for you, as well as for me, for nurses, family doctors, etc. And these are the kinds of things that we've or people talk about in these situations. The person isn't accepting their diagnosis or treatment, so they're in denial. Um, you often hear doctors and nurses or other professionals say they lack insight. That's a very commonly used term, insight, and I'll talk about what that means exactly. But then other people with less clinical knowledge or sophistication, they just say, oh, they're stubborn. Um, you know, they're in rebellion, or they're doing this because they've been traumatized by the healthcare system. And um, I won't deny that that can happen. Um, the healthcare system can be a little harsh, maybe very harsh sometimes, can be unresponsive to people's needs. But that doesn't necessarily explain why someone doesn't want to go for help, although it may play some role. You might hear people say, well, they can't accept their diagnosis, they can't reason through things because they have brain damage. Or perhaps of less common nowadays, but back in the 1960s and 70s, under the influence of anti-psychiatry authors and activists, people would say things like, "Oh, well, it's actually a spiritual crisis. It has nothing to do with health or the brain." Um, so, all these things, at least many of them, could apply to certain people with mental illness at certain times. But it still isn't an adequate explanation for why some people who are affected by something like schizophrenia um, just, behave as though there's absolutely nothing wrong with them and reject any efforts um, to have some sort of intervention or treatment. So let me talk about this concept, insight. This is as I was mentioning, a very commonly used term. It's in the DSM, it's in all the textbooks. And we do an assessment of every patient's insight when we do an evaluation, when we meet with every patient. A psychiatrist will write what we call a mental status examination, which is a description of the person's appearance, behavior, thought, process, mood, and their ability to kind of collaborate and recognize their disorder. Every time we see a patient, we write that up. And, so we comment on this insight, this concept of insight. It does mean a lot of things. However, it's not the most precise term. So in psychotherapy, especially in the heyday of psychoanalysis, insight was considered kind of not perhaps a continuous state of mind, but sort of an event, a burst that happens through the course of therapy, a breakthrough of understanding, of getting past some emotional impasse. So historically, it was used in that way, and the idea was you do enough therapy, you have an insight, and you're cured. But of course, that was very naive. We know that's not the case anymore. Another way to use this word is, in common parlance, just someone's awareness of how they come across to other people. And so, again, it doesn't have to have a clinical significance when you're using it this way. Just, whether that given person realized that maybe what they said was a little inappropriate at a party, or whether, they were, their table manners were poor and they didn't quite get that or whatever. And that goes to the next point, which is whether someone can recognize the effect of their behavior on others. And, the ability to recognize that, how you come across to other people, again, it can be a personality trait or it can be a state. based upon a particular state of mind, a mood, or perhaps the onset of a mental disorder or dementia or something. And then the way that we typically use it in clinical terms is it really has to do with the recognition of the symptoms of a mental disorder. That may include the inability to recognize how the person comes across to other people, but it also has to do with the recognition that the strange things they say are the product of the mental disorder and don't reflect reality, or that the fact that they're spending hundreds or thousands of dollars in racking up credit card bills, it actually has to do with their being in a manic state and not, it doesn't have anything to do with the actual balance in their bank account. um, and then that also affects their ability to accept the diagnosis, uh, and therefore a need for treatment. So it's really the last two aspects of insight that most of us in treatment of people with mental disorder, that most of us are trying to assess, and that we will be commenting on in our notes and perhaps in our discussion with the patient and families. So in severe mental illness, of course, these abilities to recognize symptoms and to accept a diagnosis are reduced, and in some cases, they're essentially absent. So in that event, when insight doesn't exist, we might start using a term like anosognosia, or perhaps denial, but denial and anosognosia are distinct, and so we'll try to understand that distinction. So let's start with this funny word, anosognosia. So the etymology is broken down here. So basically, the lack of knowledge of disease. And it's not that old a term, a little more than a century ago. This famous neurologist, Joseph Babinski, used it when he was describing a specific syndrome that occurred in people with a stroke on the right side of their brain. The stroke in the right cerebral hemisphere, the kind of top part of the brain, it controls movement, controls sensory input from the left side of the body, vision on the left side, etc. So when those things are reduced or destroyed by a stroke, it also seemed to be accompanied by what he called neglect, a very interesting thing. This is how I learned this term anosognosia in medical school. It wasn't in the context of psychiatry. It was from neurology and a lecture that I remember by Dr. Kibler, who was kind of my mentor in neurology at Emory University in Atlanta. And I remember his describing this, and I thought it was quite fascinating. So the person with a right-sided stroke can't move the left side of their body, but they also ignore that side of their body and of their visual field. And you approach them, and they don't see you. They don't even sometimes recognize that the left side of space exists. And then they also lack recognition that this is a problem, or even that they're paralyzed. And that is how he applied this term anosognosia. The people don't recognize that they are paralyzed, that they've had a stroke. And it may be irreversible, although people with strokes can get better through rehabilitation, and the severe anosognosia and neglect can gradually improve in some cases. But the fact that this is sort of the classic description of anosognosia, that being due to severe brain damage, does indicate that it has something to do with the function of the higher levels of the brain, the cerebral cortex. So, what about denial? Um, it's again very common to hear someone say, "Oh, they're in denial that they have, psychosis or bipolar or Alzheimer's, so that's why they're not cooperating." Um, but denial is not predicated on some kind of neuropsychiatric disorder or loss of brain function. It is considered a psychological defense mechanism. Um, and if you read, sort of classic psychoanalytic uh, theory, going back to Freud, um, it's considered a so-called primitive defense mechanism. So something terrible that's happening in a person's life is suppressed. Um, and it goes unconscious. This is the classic theory. And when that is um, complete, it's considered denial. So the person would just pretend like their spouse hasn't left them, and they'll talk about their spouse as though they're coming home that evening, but in fact everyone knows that they've run off with another person, whatever. So that's sort of a Hollywood version of it. But this psychological defense mechanism of denial is prevalent in certain conditions like addiction, personality disorders, and even in acute psychological trauma or medical disorder, like someone with severe chest pain having an MI, going about their business and saying, "I'm having indigestion," while clearly they look quite sick and they're just not willing to accept the fact that something terrible is happening. And so they may have to be persuaded to go to the hospital. That's not common, but it does happen. And, I won't dwell on this too much. Um, Denial, though, is considered to be amenable to some psychotherapy. Um, and it usually does resolve with time, but in people with addictions, it can be quite stubborn and again, a very frustrating situation. And sometimes I wonder if someone is using certain substances repeatedly, whether it does develop into almost a kind of anosognosia, but I think there has to be a lot more research before we make that conclusion. So how does it apply to mental disorders? Um, And this is fairly recent. I mentioned that it was recognized in neurologic disorders, a little more than a century ago, and for mental disorders, really going back just a few decades. Um, there are early mentions of it as an aspect of severe schizophrenia in the 1990s. And I'll talk about, someone in particular, a psychologist who's done the most work in this area, but other disorders may also merit this kind of a description or understanding. So anorexia nervosa, people who uh, have severe forms of anorexia for years and years, and who are persistently underweight, um, their brain function is compromised, and they get to the point sometimes where they just can't recognize that it really is a disorder that requires medical treatment. And anorexia is actually considered by some people the most fatal psychiatric disorder because of a high rate of both suicide and self-starvation. And of course, dementia and Alzheimer's are neuropsychiatric conditions, but um, you know, it's clear that especially in some frontal lobe types of dementia, that there can be a lack of recognition that anything is going wrong or changing even earlier in the disorder. And so people's who are affected by this, their behavior can start to change in ways that's very distressing to those around them. Again, they don't recognize the way that their behavior is affecting other people. And, they can, of course, in the worst cases, become aggressive, but sometimes it's just more social inappropriateness and they just don't get it no matter what feedback they receive. And sometimes this is, not recognized as a form of dementia initially. And then there's bipolar disorder, especially severe mania, with or without psychosis. Um, and in that state of mind, of course, there's often a lot of euphoria, grandiosity, and you know, com impulsive behaviors, um, indulging in behaviors that are, very pleasurable but highly risky, gambling, um, very promiscuous sex, spending, and all of that. And so, in the height of those states of mind, some people just refuse to accept that there's anything wrong or to, receive any kind of intervention. And then finally, there's obsessive compulsive disorder. Um, and in DSM, there's actually a mention of a form of OCD with lack of or poor insight. Um, and this is not very common, but there are some cases where a person is so severely caught up in their obsessions and compulsions that they have very limited or perhaps no recognition of their disordered behavior and how it affects them and other people. Um, about 25% of people with schizophrenia, by the way, do have some aspect of OCD, so they can coexist, and that can be very tough to treat. All right. Why I think I'd like to pause here because I've said a lot already, and maybe just take some questions for, let's say, 5 minutes or so. Just make sure that, I'm coming across to everyone.
I have a bit of a complicated question, but I will try to simplify it. So I'm the caregiver to a partner who has bipolar, who readily tells everyone they meet that they have bipolar. It's almost like an accessory, if you will, if that makes any sense. However, in our day-to-day relationship, my partner will have, you know, several outbursts, rage, anger, always directed at me. I'm the only person in the world that brings out this rage. So I'm just wondering what your comment is on someone who can admit, or not, I shouldn't say admit, that's the wrong word, who can state and identify with having a mental illness and the general definition of it, yet on a day-to-day basis, they deny that their behavior is due to that, and they tend to send the blame, well, in my case, to me, um, constantly. And I know from other people that are surrounding us that it's irrational behavior. It's not balanced behavior. So question is that also a form of this?
Well, I would certainly say that insight can have, as I was mentioning earlier, different aspects to it. And I wouldn't use the term anosognosia unless it was really completely absent. Um, and there's no possibility of a conversation really about, the disorder and its treatment, at least not without a lot of effort and work. And we'll talk about a method or approach for that. But in any event, otherwise, people's insight can fluctuate over time, depending upon, obviously the severity of their symptoms, whether they're accepting their medications or taking it properly, whether they're using other substances, how much stress they're under. So, every situation is unique, so I can't really comment on specifics in your case, but I would say that there's, some aspect of insight that seems to be missing. But certainly being aware of a diagnosis and that it requires treatment is suggests some level of insight. But I think that a doctor would have to assess, the kind of all of the components of that to fully understand it.
You. There's also a question about treatment ideas for working the issue with working this issue with folks that have schizophrenia.
Yeah, we'll come to that a little bit later, I think, in our discussion tonight, in my presentation.
Excellent. Also ways to overcome objections with someone with anosognosia.
Right, same thing. We'll
Come to it.
yeah.
Okay.
Yeah. Solutions. I mean, that's what everyone wants, of course. So we'll try to spend some
Yeah.
time on it.
And what would you say is the most clear difference between denial and anosognosia in a person with psychosis? Is there a clear indicator or test that a caregiver can give?
Well, I don't think so, long and the short of it. However, in somebody with well-diagnosed schizophrenia, who doesn't recognize the condition or the need for treatment, I'd say that's most likely anosognosia. And denial, as I said, is more common in people with more intact reality testing, a higher level of function in general, and can be associated with, not always, but sometimes, some sort of unexpected event or, but then there's also um, the aspect of addictions, substance use disorders, where people don't kind of recognize how that's affecting them and people around them. And I think that does require more research, as I said. It sometimes seems to go beyond just a psychological defensive denial, but none of us that I'm aware of is really prepared to call it anosognosia at this point. But there is something there that can be extremely difficult, can make it very difficult for those of us who want to work with and care about somebody with a severe addiction to make any progress.
Okay, and another one. What is used to determine this diagnosis or condition?
Well, I mentioned a little while ago this interview format that we call the mental status exam. So, that's certainly the first step, but there are other assessments that we do in certain cases. At the BC Psychosis Program at UBC Hospital, we do neuropsychological testing on many of our patients. So we have a neuropsychologist who, has been trained to administer and interpret these tests. And people with schizophrenia and also some people with severe chronic mood disorders like bipolar disorder, and certainly people with dementia also lose other aspects of their cognition, of their ability to think, remember, solve problems, figure out how to carry out a sequence of events. Those are what we call executive functions. And those cognitive impairments can be an enduring aspect of even schizophrenia. And play a big role in the functional impairment, the inability of people to, get a job, to have relationships, to have, adequate social function in general. So we find that people with more severe cognitive impairment also tend to have less insight. And so, in certain cases, that kind of assessment would be helpful as well.
Great. Okay, Susan also mentioned, my daughter and a group of friends all had long-term professionally facilitated group-based psychoeducation about schizophrenia. Schizophrenia at the long gone UBC Schizophrenia Day program. Except in early psychosis intervention programs, this kind of education doesn't seem to exist for clients now. I think some in my daughter's group had some anosognosia, but by the time they finished with this program, accepted their illnesses, and except during periods of psychotic relapses, they've continued to accept their illness. So her question is, why has this kind of why has this kind of psych ed not become more prevalent? Sorry, Susan, I'm trying to read in the chat. So are you aware of that program? And
Yes, I never worked in it, but I'm certainly familiar with
Mhm.
it, or heard about it, and spoken to one of the doctors who was affiliated with it. And that kind of a intensive psychoeducation can be extremely beneficial for patients and for families. I think a lot of the family education, of course, has been handed over to organizations like yours and to BC Schizophrenia Society. And with its multiple mandates and staffing issues and different I guess changes in leadership over the years, the focus on this for patients has not been carried through. The early psychosis intervention program is meant for people who have a first episode of psychosis, in order for them to get this kind of education, and for their families to have extra support early in the course of their illness, because programs like that, we do have one now in the North Shore as well as Vancouver and Richmond. Programs like that have evidence backing up their effectiveness in improving outcomes for people with severe mental illness. So at least we have that.
Okay, so
But not everyone gets
Vancouver-
access to that, or is even recommended to get that at the appropriate time. Sorry.
No, that's okay. So that's through Vancouver Coastal?
Yes,
Yeah.
early psychosis intervention. And there's actually a provincial website for early psychosis intervention that anyone can look up, and it indicates where those programs are in different communities in the province.
That's great. They do sound really, really important. Okay. So I'm just
Should I go
yeah, do you
ahead
want to
and
keep
cover some
going
more?
and we'll take some more at the end? Thank you, Dr.
Sure.
Mike.
Okay, so we talked about that. So what are the impacts? I've already more or less mentioned this, but I'll just make it more explicit. So people with anosognosia don't accept that they have a mental disorder. They're convinced, for instance, if they hear voices, if they have delusions, they're convinced those are real, to the point that they will react to them. They will talk to their voices. Now, I'll just say that people who talk to their voices don't necessarily have anosognosia, but at the same time, the more kind of involved someone is with their psychotic internal state. And the more they kind of shut out the outside, I think the more likely that they're going to be unable to recognize that it's a disorder. At least that's what we see in people with severe schizophrenia at the BC Psychosis program. And so they may react with dangerous behaviors as well if they're convinced that, they have to go. We had a patient, who was convinced that her lover was waiting for her in some foreign country, so she eloped to YVR and managed to get on an airplane. The airplane didn't take off with her in it, but anyway, things like that can happen. Of course, they will refuse to take medication because that will only, it makes no sense to them that they should need treatment. And furthermore, if it reduces their voices, sometimes they don't want to lose their voices. Of course, they will also refuse to go to appointments or to the hospital, and they'll require involuntary treatment in many cases. That's one of the criteria of the BC Mental Health Act, that the person is not suitable for voluntary treatment, I think is the language. And basically that means that they lack insight or they even have anosognosia. And if given a choice, they would just walk away from the hospital, walk away from their appointments, and refuse their medicines. And, that puts them and people around them possibly in a risky situation. So I mentioned that we'll talk about some possible, solutions. And that we're going to talk about solutions in ways that you and other families can try to get help for situations where this kind of thing is going on. And maybe I didn't already say, what proportion of people, for instance, with schizophrenia have this? I don't think we have a precise estimate, but I keep seeing something like 30%. It depends upon the population. And again, at our program at UBC Hospital, where we have people with more severe forms of psychosis, I'd say it's probably approaching 50% or more. In first episode psychosis, it can be fairly intense in some people initially, but then with the psychotherapy, with the treatment, with the education, they do gain more insight. So I'd be reluctant to make a diagnosis of anosognosia in a first episode because some people do have improvement with the proper treatment. But I guess I want to tell you about this. I think many of you know this author's work anyway, but Dr. Xavier Amador had a brother. He's a psychologist, and his brother had schizophrenia. And he observed, this going on with his brother who was refusing treatment. And so, being trained in neuropsychology and understanding, for instance, Dr. Babinski's observations, and the fact that, there was more neuroscience back in the 90s and 2000s when Dr. Amador was writing papers in this book. This book was published in 2000. He realized, I think this kind of applies to this population too, not just people with strokes. So he eventually, started talking about his own experience with his brother, and developed an approach that can be quite helpful for professionals and for families. So he's developed this organization, the LEAP Institute, which is an educational organization basically for professionals and families affected by severe mental illness. LEAP is an acronym, standing for listen, empathize, agree, and partner, which is kind of the steps he recommends for trying to make some headway in people affected by anosognosia with severe mental illness. And, you know, earlier I showed one of my slides that listed all the reasons that we could come up with. And of course, for why somebody refuses care, you know, and things like they're stubborn, they're in denial, or they're just, you know, use an expletive. When frustration reaches that level and, you know, voices are raised and there's a clash, a conflict, I think many of you have observed that really doesn't help. But we're all human, and that frustration is intense. And so when you see someone suffering, when you feel the suffering yourself, you know, you can lose patience. So once you can understand perhaps the fact that people with these mental disorders are not just being stubborn, that they could have an explanation as it is part of their disorder, the lack of insight, the anosognosia, then perhaps you can get around your frustration and channel it into something more productive. So that's what this is all about. He calls it transforming the relationship. So, you know, getting past the anger, the fear, the anxiety, so that you can try to be a little bit more empathic and creative to overcome the lack of insight. So anyway, he's offered quite a few things, including workshops and videos and webinars, etc. You can go to the website. According to the website, he was in BC in 2012. He did a training. I don't know if anyone attended, but but of course he's from the US, so that's where most of his activities are. You know, when I look into this, I realize that it's kind of a form of what we call motivational interviewing, which was a technique developed several decades ago for intervening in people with addictions, especially initially really for smoking cessation. It's based on this model of stages of change. It also goes by the trans-theoretical model. And that has a little acronym too, but anyway, I won't go into all that. But the idea with motivational interviewing is trying to move a person along a pathway of change. Now, people with anosognosia are not necessarily going to change and have that moment of insight that I talked about earlier, that psychotherapists aim for, you know, that moment of insight, and everything will suddenly become clear and you'll understand and you'll be a different person. That's not what we're talking about here. So I don't want to get your hopes up inappropriately. But we are talking about shifting a relationship, you know, that you or even a therapist or a doctor, whoever has with the person affected, so that you know, you can avoid alienating them further. So that can sometimes mean to just listen, even though they're telling you things that make no sense, trying to suppress your reactions, finding the little kernels where you might be able to agree and work together in a direction that you know could be helpful, even if it's just a little bit. So that's really what this is all about. That's the LEAP approach, which, as I said, really aligns with this technique of motivational interviewing. There have been trials and there is research. It's not extensive, but there is something out there. For instance, a randomized controlled trial published in 2009 that showed after a couple of months improved, motivation for change, adherence to treatment, etc. And of course, in the end, that is really what we want. We want them to be able to accept treatment, to stabilize, and then hopefully get better enough to engage in rehabilitation programs, let's say, like a day program that Susan mentioned. Well, I wish we had a day program still, but we don't right now. But, maybe they could still go to a mental health team and attend a couple of groups, or maybe they could go on an outing with their caseworker or whatever. Maybe small steps they can take, but they'll never be able to take them if they're not at least going to their appointments and taking their medication. Another study actually looked at the training in this approach with 88 relatives of people with severe mental illness, and found that at 3 months out, which is not a long time, studies like this are hard to do and hard to get funding for. But anyway, there was improvement in the relationship between the family members and the affected people, as well as their socialization. Maybe there'll be more research coming on this, but it's kind of what we have to go on for now. And, I'd encourage any of you who think that this applies to your loved one or the person that who has one of these disorders, maybe to consider looking at the website or even reading one of Dr. Amador's books. And then you can, mention it if you accompany someone to an appointment, let's say, like you read about this, bring it up with the case manager, let the doctor know that you wonder whether the person could have severe lack of insight or anosognosia. So if you're a little bit more educated and sophisticated, that may help the treatment team as well. So we'll stop again for some questions.
Thank you so much. There is one in the chat here from Nancy. Have you any thoughts on cognitive enhancing medication such as donepezil? Is that right? Or memetine? Would they help in a person recognizing their illness, in having more awareness of their psychosis?
That's an interesting thought. The answer is I don't know, but I can explain that for those of you who aren't aware, those are medications that are used to treat dementia. Medications for dementia are more focused on improving memory in general, improving memory function. That can be affected in schizophrenia, certainly, and in depression too, for that matter, severe depression and bipolar. So we do use those. Well, donepezil, not so much, but memantine is something that we're kind of interested in, and there are some clinical trials for memantine and schizophrenia, not necessarily for anosognosia, but more for negative symptoms and some of the other cognitive impairments. It's not anosognosia and schizophrenia. I have to also say it's a little bit controversial still. It's not, something you'll see necessarily in a lot of research papers or textbooks. But there's some growing recognition of this, thanks in part to Dr. Amador's work. So hopefully medications could be studied as well in the future. I will mention that, cognitive impairment is schizophrenia, and anosognosia is probably an aspect of that, but it is the most important thing in determining someone's long-term outcome and function. There was a study underway, a clinical trial of a medication we had a lot of hope for, that a German pharmaceutical company has been doing. And the bad news is that just last week they announced that the phase 3 clinical trial did not meet the endpoints. So that means they're ending development of that product. And there have been a number of products for cognitive impairment and schizophrenia that have been studied and just have not worked out, which is quite unfortunate.
Shirley has a comment. Might it be possible to partner with Redfish Healing Center to survey or study the impact of motivational interviewing?
Well, that's a good point, because of course that is the provincial center for people with concurrent mental health and addiction problems. And I know that motivational interviewing is part of their program, but using motivational interviewing with somebody who wants to quit smoking versus using it with somebody, who doesn't have a mental disorder, versus somebody with concurrent methamphetamine and use and psychosis, those are probably very different populations. So I do think that we probably need to, look at it in that population and adapt it better. And I wonder if Dr. Amador has thought about that, like how the LEAP approach could be tailored to that population. Yeah, it's something to think about.
And there was another question around research. Has there been any research at UBC about anosognosia and severe anorexia nervosa?
I'm not familiar. The research on anorexia nervosa in BC, I think, is fairly limited. I think they may be doing, if any, some at St. Paul's or BC Children's Hospital. Those are the two tertiary sites for severe eating disorders. And I know there was a psychologist working with the eating disorder group at St. Paul's, but I haven't been in touch with that person recently.
Thank you so much. Some really, really important points, and my journey with my son. What one of the moments, really a pivotal moment for me, and the leap really fits in here, was he was determined that his grandfather was a Nazi bastard and that they should put limestone on his grave. And it's all he would say while I tried to convince him otherwise. While I tried to reassure him that he liked his grandfather, while I tried to, talk him out of it, while I tried to use logic and, questioning, and then finally the penny dropped for me, and I realized that he had probably been talking to my father, and my father had probably said, Dan, you should really go to work and look after your mother and not be sitting at home. And that just, I realized that's probably what was underlying. And I said to Dan, it must be really hard not working. And the shift we were driving at this point. I had finally taken him out of his place and we went for a drive to try and work through this. And it was tangible, the shift. And his answer was yes. And that's the first thing he said, other than Nazi bastard and limestone, over a course of, the phone call and then the car ride. And then the second thing I said, we've agreed that you are not to go back to work and I'm to look after you. So you're not doing anything wrong. And then I said, it must be really hard taking money from your mom. And again, he said, yes. And the shift was so dramatic. And within 5 minutes, we were at a takeout, and I said, listen, let's get something to eat. You stay in the car, because I figured there was no way he could handle a crowd. He walked in, he was fine in the crowd. The shift was so dramatic. So this LEAP method is absolutely critical. Listening and understanding what's underlying the outbreak or outburst or whatever, paranoia, the fear and the anger. Anyway, that's all I want to say. Thank you.
Yeah, so you're able to empathize about his loss of ability to work, you know, which is something that many of my patients say, you know, I would like to go back to work. I just, you know, I can't, or, you know, it's just a very big loss for many people. So I can see how your ability to finally recognize what he was talking about could make a difference.
We've been talking about LEAP and how to talk to your loved one. Did you have anything else to add on that?
Well, as I mentioned, the Mental Health Act, um, you know, basically recognizes that this is a part of severe mental illness, even though it uses, you know, legalistic language. But having to go before a judge to, you know, get someone taken to hospital for treatment is, you know, hard and probably traumatic for anyone who's had to do it, and certainly traumatic for the person who gets arrested and taken to a hospital. If it's life or death, though, that's kind of the choice we have at this point. But you know, all I can say is I feel terrible when that has to happen. But um, you know, getting someone to a hospital is better than, you know, they're ending up, let's say, in you know, detention in a jail or something. And I think we do a little bit better with that here in BC than, you know, in some other jurisdictions. Also in BC, fortunately, we're allowed under the Mental Health Act to treat people, even those with anosognosia who would never consent to treatment. You're probably, some of you, aware that there's a challenge to that aspect of the mental health law in BC that's going to be heard later this year. So I know BC Schizophrenia Society is paying close attention to that.
Thank you. Nancy Murphy also mentioned that her daughter passed away just in February last year after 28 years of severe OCD and anorexia. It was diagnosed at 11 years old at the Hospital for Sick Children. And just over those years of 28 years of care, anosognosia was never mentioned, mostly shame-based in Canada based on BMI. So sorry for your loss there, Nancy. And yeah, it's important to be able to speak about this. Okay. And any other questions? I'm trying to see in the chat. It's a little bit hard to see in the chat here. Any hands raised?
I see a question, I think from Deborah.
Yeah, oh, I see that one. For someone with anosognosia and unmedicated because of refusing treatment, is there a therapy methodology that has a better success rate in working with someone with schizophrenia?
So I'm not sure if better is related to medication or to LEAP or I mean, there's another, excuse me, therapy that has some overlap with perhaps sleep or even motivational interviewing. in some ways, which is cognitive behavior therapy. It is used in people with psychosis. There's a form of it developed for that. The thing is that for someone with anosognosia, I don't think we have a lot of evidence that it can make a big difference. It can help reduce distress in some people who have, voices or, distressing delusions, and they are kind of motivated to find new ways to cope. I see DBT or acceptance therapy. So yeah, DBT is in some ways a form of CBT with a focus on kind of distress tolerance. And it's, of course, a commonly prescribed treatment for borderline personality disorder. And I don't think that the concept of anosognosia in general would apply to something like borderline personality disorder, although in severe cases, some people do refuse treatment, are very difficult to work with. But in any event, yeah, DBT is not a treatment for anosognosia per se, and I think it would be hard to use it in such a population. It does require quite a bit of kind of commitment to going through the therapy. It's done sometimes in groups, sometimes individually, and it requires a very strong kind of therapeutic relationship be built between the therapist and the patient. That can certainly happen in any mental disorder. And I think people with schizophrenia, even with anosognosia, can develop a relationship with their doctor, with their case manager. It may be based on goals other than, sort of a traditional therapeutic goal. But that's kind of the premise of DBT. It's more of a traditional therapeutic approach.
Okay, there was a couple of questions, one that came in before and one here. Just around, is anosognosia constant, or can a person shift in and out of it? And related to that, what is the underlying brain dysfunction in permanent anosognosia?
Yeah, I don't think we know the answer to the latter for people with severe mental illness. There are theories, based upon, neurologic cases like I described at the beginning. So, the parietal or frontal lobes of the brain on the right side, perhaps, are important. But when we look at someone with schizophrenia closely, at the brains of people with schizophrenia, there's certainly abnormalities, but not in a way you could pinpoint a particular aspect of it to a particular lesion somewhere in the brain. So and there was a second part to the question.
Well, the first part was, yeah, is anosognosia constant, or can a person shift in and out of it?
Yeah. I think it in its classic form, I mean, really, if you're going to talk about anosognosia as the most severe end of impaired insight, it would be something that's, I think, more enduring. Insight can fluctuate. Anosognosia, I'm not saying that could never get better, but it's unlikely to change from week to week, moment to moment. So it's thought of as a more enduring aspect of brain function.
Okay. And so Maria was asking too, just what are the best practices to encourage a loved one to accept treatment?
Well, I think obviously, this LEAP approach is based on trying to reduce the level of frustration and conflict, because that, when there's conflict, when there's anger, when the person perceives that, that turns on their, that activates, right? That makes people more reactive. They're expecting a threat. So when an effort to offer help, treatment, medication, whatever, is perceived as a threat, that shuts down, for any of us, really, any threat is going to shut down part of our rational decision making, the flight or fight response and all of that. So the first thing is to try to lower the temperature. Now, if we're talking about life or death situations, that's a different matter. If somebody, is suicidal, somebody is aggressive and harming other people, then there needs to be intervention. But barring that, if it's just a chronic, ongoing refusal to recognize reality and to accept a diagnosis, then trying to do the listening and empathizing and avoiding creating conflict, I think, is really what's key.
Mhm. Yeah, it's really hard, isn't it? And I think that's one of the ways that peer support groups are really helpful, that people can talk to each other about what's happening and also try to de-escalate and empathize and dig into that. Yeah. Diane also had a question. The services for severe mental illness like schizophrenia and psychosis are often combined with addictions and brain injury treatments. If someone has anosognosia, they would not feel that they are part of that group and it becomes a barrier to treatment. What do you advise?
So I know that people, patients in hospitals and sometimes in mental health housing, are in situations where there are, kind of mixed populations, and different diagnoses, different concurrent disorders, medical disorders, etc. So, that can sometimes be risky for certain patients. And I guess given the limited resources we have, sometimes we, the health system, and a lot of the mental health housing, by the way, is partially or largely funded by the health budget. However, it's often run by nonprofit organizations. So they're under contract. And so anyway, it's complex, and every community has different resources, different organizations that offer housing. Health authorities have differences in the way they deliver care. So I don't know if I can really answer that question directly, other than to say that your advocacy may not always seem to make an immediate difference, but I think that it's crucial to try to push us in the right direction in individual cases as well as, in the larger system.
Mhm. Thank you. And There was a question with long-term force treatment, is there a better chance to lessen anosognosia? And Shirley actually commented that her daughter received long-term treatment, and when stabilized with the medication, she had a sense that she is ill and needed help. So she felt that once stable for a lengthy period, she did regain some of that.
Mhm. Yeah, so you know, this is not always black and white. It was that, and we do know that in acute psychosis, insight is often very poor or absent. When the psychosis subsides, the person, or when the mania subsides, or whatever, realizes, oh gosh, that was terrible. I don't want to go through that again. I wouldn't call that anosognosia. You know, if after the acute psychosis resolves, that insight is coming back. You know, in people who either don't respond to treatment or who, despite having some improvement in their delusions and hallucinations, still refuse to accept it was an episode of psychosis or whatever, that's when I would start entertaining that diagnosis. So as far as long-term, treatment, like either in a tertiary mental health facility or in the community on extended leave or community treatment order under the Mental Health Act, people can be required to take medications for long periods of time. Some of them may be on, medications that they receive by an injection every 2 weeks, every 4 weeks. There are now forms of medication that can be given every 3 months even. A form of paliperidone. So is there a better chance to lessen anosognosia? I think again, it's something that probably needs more research to really understand. And if someone is on long-term treatment, 3 months, 6 months, a year, and their insight gradually improves as their psychosis gets better, was that anosognosia? I'm not sure. Retrospectively, I might revise that, but again, if after a year of treatment there's no improvement in insight, I would certainly say that's likely anosognosia.
How to persuade the treating psychiatrist to stop allowing extended leave to lapse so as to prevent perpetuation of all the trauma, dangers, and revolving door.
Well, gosh, I mean, extended leave can lapse just because, I mean, the worst case scenario, I guess, medical legally is that, the team forgets to renew it. It has to be done by a certain date, and if it's not done, then the extended leave is kind of null and void, and we can't renew it in the community. Extended leave or mental health certification has to be done in a designated facility, a hospital. So if someone's extended leave ends by whatever means, to get them back on it, they have to reach the point where they require acute hospital care again. So that, can perpetuate the revolving door thing. And I know that must be very frustrating for you to watch, and it's frustrating for the mental health system to have to do this as well. Sometimes people can be released from extended leave by a review panel. And those happen in the community or in the hospital. And the panel has the authority not to change any aspect of treatment other than whether the person is still subject to the Mental Health Act or not. And patients have the right to request that once per cycle of a mental health certificate. In the community on extended leave, most mental health certificate cycles are 6 months. So the team has plenty of time to anticipate that the renewal is coming. Anyway, I guess there's the review panel, there's just the forgetting to renew it. And then the third way for an extended leave to end is for the doctor and the patient to, decide one way or the other that it will end. The patient, persuades the team, I'm doing fine, I'll take my medication, etc. And if, according to the Mental Health Act, if somebody is considered suitable to be a voluntary patient, then they're supposed to be made voluntary. And again, some patients may say, well, if you don't make me voluntary, I'll just ask for the review panel and they'll let me go. They did it last time and they'll probably do it this time. And, a lot of doctors, a lot of mental health teams find review panels to be somewhat burdensome and stressful. So, and if they think the person could be released anyway, they may just say, okay, well, we'll end your certification. So these are all the dynamics at play. And I can understand that as a family member, you would be upset or frustrated that the extended leave is ended. And you certainly have the right to try to ask questions and understand what's going on. But, just so for your awareness, it's not always a simple or black and white kind of process.
Yeah. Now Teresa is saying that she has a loved one who's been able to trick psychiatrists that he's completely normal when he's psychotic. Is this part of anosognosia?
Maybe. On the other hand, that does suggest some self-awareness about how the person is coming across. And so I don't know. I think I've seen situations like this. And again, I'd have to do an examination or whatever to know for sure. But somebody who's that clever clearly may not have a lot of the cognitive impairments that could suggest the likelihood for anosognosia. But I have certainly seen intelligent people affected by psychosis who are still superficially functioning at a high level, and could pass, I hope this doesn't come across as flippant, but what we call the bus stop test. So if you walk past someone waiting for the bus, and they don't, they're not talking to themselves, they're not wearing layers of clothing or have some other telltale signs that we see in people with severe mental illness on the street who are not getting adequate care. So that's the bus stop test. And we've certainly had patients, I have one now actually at UBC Hospital, who passes the test, but you spend 10 minutes interviewing the patient and you realize how thoroughly psychotic she is and how her mind is on two tracks at once. The track in reality, to get by her day-to-day activities, and then the track of, this other thing is happening and it's real and you can't persuade me otherwise. And I think that is, she has anosognosia.
Connie asks, so then when a psychiatrist says that the patient lacks insight, does it mean the patient has anosognosia?
No, insight is something that is on a continuum, and at the far extreme of the continuum is anosognosia. Yeah, the most severe lack of insight that doesn't seem to respond much to treatment or other interventions, at least only in the most kind of subtle and gradual ways. Which is what I'm trying to say. It's not that there's no hope, but in true anosognosia, it's not going to get better with just a few weeks of medication.
And this Aurora says this kind of goes with what was said before. Say someone recognizes their schizophrenia when they are on meds for a while, but only takes them when they are involuntarily admitted and mandated to take treatment. But once they are released or at any chance they get, they go off their meds. And as soon as that happens, they don't seem to notice their illness and seek no help for it. Does that mean they have anosognosia that comes and goes?
Well, I'm not sure. I think they have lack of insight that fluctuates, but I think in some cases we see that the lack of insight fluctuates initially, just like the psychotic symptoms, but then over time, they may not respond as well to treatment. The medication, the hospital stays, whatever, don't seem to make as much difference, and then they, could develop what we call treatment-resistant schizophrenia. And I think anosognosia is more common in that population. And that's the population in which we tend to use the medication clozapine, which is the only approved medication for treatment-resistant psychosis. And about 30% of people should be taking clozapine. 30% of people with schizophrenia or schizoaffective disorder should be on clozapine, most likely, because that's about the proportion that have treatment-resistant disorders. Unfortunately, it's an underutilized treatment in Canada and in BC. We are making efforts to try to improve that, at least in Vancouver. And so that's another thing you can bring up in your interactions with the mental health teams. If your loved one isn't getting better, they've been on 4 or 5 meds, they still are having symptoms. So clozapine might be an appropriate treatment. No, clozapine doesn't cure anosognosia any more than any other antipsychotic. But again, the person may have more of a chance at recovery, at least of improving their quality of life if they're getting that medication.
Okay. And Teresa mentions that her loved one won't join a support group because he can't stand those kinds of people. This must be denial or anosognosia. He has what these people have. He is bipolar 1.
Well, possibly. We talked a minute ago about, the fact that groups, hospital wards, mental health housing units have, different groups of people. And, what we have to offer in the system isn't that personalized at times. And, so some people may have had bad experiences with other patients. They may, or, it could be paranoia. There could be lots of reasons. One of the reasons could be that they don't recognize their disorder resembles those other people. So maybe that is either poor insight, anosognosia. Again, this would have to be a subject of exploration by, one of the professionals involved in their care.
Okay, and Susan asked, does anosognosia occur with borderline personality disorder that is concurrent with some psychosis?
Um, you know, I haven't seen the term applied in borderline. I'm no expert on borderline personality disorder, but I think probably it's unlikely that many psychiatrists would apply it in that case, but uh, and people with borderline can have some episodes of psychosis, and people can have borderline personality and schizophrenia, or borderline personality and anorexia, or bipolar. So, you know, there can be a number of diagnoses present at one time. So, you know, I'm sure there are patients with borderline and one of these other conditions who have an aspect of or have had anosognosia. I don't doubt that.
Okay, thank you. I know there's, I'm not sure if we got to all of the questions, but I know it's also getting to 9 o'clock. So, maybe we can send them after or something, but, I do want to be mindful of time, and thank you so much for your time tonight, Dr. White, and for everyone who came tonight and shared your stories and your experiences and your questions. So thank you so much for that. We are recording this, and we will be sending out the recording in our February newsletter. So we'll have that to you hopefully by next week. Mhm.
All right. Well, I enjoyed speaking to all of you, and I wish you all the best. I know that having a loved one with these disorders is extremely difficult, if not overwhelming. And you know, the healthcare system is not always the most responsive, but we'll keep trying.
Thank you so much. Yeah. Thank you, everyone.